Hello, colleagues. I'll be discussing whether we can manage glaucoma without ocular hypotensive medications. These are my disclosures. We do have many treatments that lower IOP instead of or in addition to medications. The traditional options that we are well familiar with are listed here. Recently, there has been an explosion in the number of surgical procedures and devices for lowering IOP in a less invasive manner. Most of these devices are listed here. New ones are on the horizon. We continue to define the range and duration of efficacy of these newer devices. The goal of glaucoma treatment is to achieve an IOP that prevents progression and achieves stability in each and every patient. Target IOP guidelines have been established from many large prospective clinical trials, and recommendations have been prepared by the American Academy of Ophthalmology, the European Glaucoma Society, and others. The guidelines for setting target IOP are listed here. These are general guidelines, and in each patient, it is important to assess risk parameters in addition to stage of disease. Once identified, in some patients, we can hopefully get ahead of progression, treating more aggressively, and in other patients, we may be able to step back, accept higher target IOP, and carefully assess the most appropriate therapies. Once we set a target IOP, how effectively can we achieve it, and with which non-medical treatments? The range and duration of efficacy with alternatives to medical therapy has been evaluated in many studies. SLT as a primary procedure in newly diagnosed patients has been carefully assessed in the LIGHT trial. During 3 years of follow-up, mean IOP was 16.6 millimeters of mercury. 78% of patients remained stable without ocular hypotensive medications, and 77% of patients required only one SLT. It's important to remember that more than 80% of the patients enrolled were diagnosed as ocular hypertensive or mild glaucoma, so the results of this study may not apply to all of our patients. Target IOP was defined as a reduction of 20% or 30% from baseline, depending upon patient characteristics. Prior to the introduction of MIGS, cataract surgery alone was observed to lower IOP. The control groups, cataract only, in the COMPASS and HORIZON studies supported the finding that some patients do have sufficient IOP control and do remain medication-free following cataract surgery alone. Although the number of patients with adequate medication-free IOP control post-cataract extraction alone is smaller than the number of patients who had a MIGS device added to the cataract surgery. Additionally, IOP reductions wane over time, particularly following cataract extraction alone, as you can see from the data here. The MIGS literature continues to expand. The number of available devices continues to increase. Intraocular pressure following these devices ranges from 11 to 20 millimeters of mercury, with patients on anywhere from almost none to 2 to 3 medications. Most often, intraocular pressures post-op are in the 15 to 17 millimeters of mercury range. So some patients will remain medication-free for a period of time post-op. The large range of observed efficacy and duration is due in part to patient selection, procedure selection, and the surgeon's technique and experience. The more invasive surgical procedures, such as antimetabolite enhanced filtering surgery and CTONs, demonstrate IOPs post-op that are often lower, in the low to mid-teens, with reduced medication requirements. And these studies that are well known to all of us do have follow-up of up to 5 years. We are well acquainted with the risks and benefits of most of our options, so each of us needs to consider whether the current order by which we select treatments is best, or if the order needs to be modified. Should we be considering more often an earlier laser trabeculoplasty, and maybe MIGS also when appropriate? We need to carefully consider when and if a patient needs a more aggressive treatment, particularly our young patients who have a long lifespan ahead of them. Another challenge for our community as a whole is to find and diagnose early disease, to find these patients with glaucoma. I don't think it's yet time to abandon the traditional, more invasive procedures, as these do more consistently result in lower IOPs. Despite the many non-medical options for managing glaucoma, we cannot at this time achieve successful IOP control in all patients without medical therapy. As we look at this list of ocular hypotensive medications, we and our patients are very fortunate to have many choices. We have excellent solo agents, combination drugs, and the recently approved bimatoprost intracameral implant. There are other classes of compounds and devices for lowering IOP under investigation. In order to achieve glaucoma management without eye drops, we need first to find a more robust means of identifying patients with glaucoma, particularly early in the disease. Patients and physicians need to accept and incorporate other treatment options, some of the newer options, in all stages of disease. And if intervention is sufficient and successful, it may change the progression curve. We need to demonstrate that surgical devices and procedures achieve satisfactory target IOPs for long durations of a glaucoma patient's life. For some patients, the current devices do meet target IOP, but the duration remains unclear. It is and it should be a goal to reduce medication burden as much as possible for our patients, and we all know the reasons why. So think again about all of the treatment options available and think about how you make a selection. For early stage patients, consider alternatives to medications. Moderate stage patients, some may be adequately controlled without medications, and some controlled with fewer medications, due in part to the newer non-medical treatment options. For late-stage disease, we need to consider the more invasive surgical options, and we have to do our best to prevent patients from looking like the one on this slide. Thank you.